Hi, I'm Deepak Bhatt, reporting for ACC.org from Barcelona at the European Society of Cardiology, and I'm here with Dr. Tony Demaria to discuss some really exciting trials we heard about. So maybe we could start off with the Atlantic trial. I think this has the potential to be practice shifting. This was a trial of STEMI patients undergoing primary PCI randomized to upstream ticagrelor in the ambulance versus just getting it in the cath lab. So what did you think of that study?
Well, the hope was that the early treatment with ticagrelor might result in a higher degree of reperfusion at the time of angiography, and that didn't happen. And in fact, looking at most of the endpoints, primary, secondary, there wasn't a lot of difference. There was a small subgroup difference in patients who had STEMIs, and they had a lower incidence of stent thrombosis over the next 3 months. So that overall I would say safe, perhaps beneficial in a subgroup, and perhaps more costly.
Sure. So I actually was pretty excited about the trial. It's true that the co-primary endpoints of reperfusion, TIMI-3 flow, that sort of thing, there was no difference between the two treatment arms. But in the overall pre-specified secondary endpoint of definite stent thrombosis, that was significantly reduced from 11 events to 2 events at 30 days. So I think that's a result that's believable. It's a secondary endpoint, but a pre-specified one, biologically plausible. And to me, it seems like it's an easy to implement idea. It's just moving the time of giving the loading dose. I don't think it's an expensive strategy if one's going to use ticagrelor anyway. It's just a matter of changing the timing of it. And it seems safe, no excess in major bleeding, no signal as far as bad bleeding goes. But I do see your point, though. I mean, obviously, long-term ticagrelor is more expensive than, say, long-term clopidogrel. But this was really just studying upfront therapy.
Yeah, and I think we probably agree. It's just that in the hopes of what it could have been, earlier reperfusion and a significant improvement of all the primary specified endpoints. In terms of what it could have been, it turned out to be nice, but not really a home run.
Sure. I think a purist would definitely agree with you. I mean, the co-primary endpoints weren't met. But nevertheless, to me, the co-primary endpoints, pre-PCI reperfusion, I mean, those are surrogate endpoints, whereas definite stent thrombosis is an important clinical event. So even though it was labeled as secondary endpoint, I guess to me it was more important. But
it is an important endpoint, no doubt.
But you're right in terms of strict trial interpretation. Another trial that was just presented that I thought was pretty interesting was the bioscience trial. And this was a trial of patients undergoing PCI who were randomized to one of 2 forms of stenting, either the second generation everolimus-eluting stent or a stent that has an ultra-thin stent strut and a biodegradable polymer. So I'm not talking about biodegradable stents, but biodegradable polymer. And the 2 stents overall were equivalent. But what did you think of that trial?
Well, I thought at the end of the day that there really wasn't an awful lot of difference. And frankly, as a non-interventionalist, I think the interesting concept is not with a biodegradable polymer, but a biodegradable scaffold.
Sure.
And so this stent, of course, had a thinner strut,
right.
and they made a big point of that, and the polymer degraded more rapidly, although it wasn't clear to me exactly how much more rapidly. At the end of the day, it's a good alternative, but not a major advance that I can see.
Yeah, well, currently that stent's not available in the U.S., but it is available in other parts of the world. But one thing that I thought was provocative was the subgroup of STEMI patients undergoing PCI in this trial, where in that subgroup there was lower stent thrombosis in the patients that got this different newer stent with the thin struts and with the biodegradable polymer. Obviously a subgroup in an overall neutral trial, but provocative. What did you think? Can we hang our hat on that? Or?
I don't know that we can hang our hat on that. We can maybe begin to take the hat off.
Right.
but hanging it, maybe we're not quite there yet. But an interesting alternative, and as time goes by and more general application, as you say, when it becomes more widely available, it may prove to have some advantages.
Yeah, I agree with you. The final study that I think we could say a few words about is the famous study which examined in non-STEMI patients FFR-guided therapy versus angio-guided therapy. So what did you think?
So I was a bit surprised at even the protocol design, because they were talking about whether or not to intervene on acute infarct vessels in non-STEMIs, when in fact I think the overwhelming data would suggest that that should be done. But interestingly enough, they were talking about lesions that were 30% obstructive or more, which are lesions that often are really not dealt with at all.
Well, in the U.S. you could get into trouble these days doing lesions like
right.
that, or at least admitting to it, yeah. So interesting question that they asked on a scientific level, but I'm not sure that many people would be stenting 30 to 50% lesions anyway, even in the context of a non-STEMI.
Even in the context, nevertheless, when you look at their data, what they found that they stressed was important was that a lesser number of patients were intervened upon than in the patients in whom therapy was guided by FFR than in the patients in whom therapy was not guided by FFR. And that they presented as a benefit. Well, if you do FFR, then that will lead you not to intervene on a larger number of patients. Again, why you shouldn't intervene on them isn't clear in the first place. But then, as a follow-up to that, they had data that the patients did equally in terms of hard events, whether they were treated medically or not treated medically, suggesting that if you used FFR guidance, you would not intervene in a larger group of patients who would do every bit as well. And so that was the end point of the paper. As I say, I could follow the thinking, but I questioned how relevant it would be in the real world.
Sure, so I agree with you. FFR has a very established role in stable patients, but whether it should extend to non-STEMI, I think we need more data before really acting on this study. Well, those were 3 of the really interesting studies presented today. Hopefully that was a useful summary. Thank you for joining us.